Hello and welcome to another episode of the AOT Pod, an FRCS-themed podcast produced by the Association of Otolaryngologists in Training with the support of the ENT UK Foundation. My name is Josh Michaels, and together with my co-host Georgie Wellstead, we speak to consultant specialists across the country tackling key themes within the otolaryngology curriculum. Today, I'm pleased and privileged to welcome to the show Ms Anya Selwyn, an ENT registrar in the KSS deanery, and Mr Rob Grounds, consultant otologist and lateral skull-based surgeon at the Royal Sussex County Hospital. So without further ado, let's begin.
Thanks, Josh. It's a pleasure to have you here today, Rob. So you finished, I believe, your training in 2021 and you went on to do a TWJ fellowship over in Vancouver, Canada. And there you studied ear surgery under the tutelage of Professor Brian Westerberg and Jane Lee. And in addition to all that experience, and if that wasn't enough, you are also a classically trained musician and you play piano, guitar, and double bass to high standard. So your combined interest in music and otology places you in a really interesting and unique position to be able to fully appreciate both the structure and function of the ear. So Rob, welcome.
Thanks very much, and lovely to be here. Thanks for having me.
So what we like to do is start off each episode with a few questions completely unrelated to the clinical scenario we'll be discussing. So my first question for you is, what did you do to prepare for the FLCS Part 2?
For me, it was actually about the two bits of being organised and secondly, finding a group of others all sitting the exam at the same time. For the FRCS, I paired up with two other registrars who were sitting it at the same time for my deanery. And we were very organised. We sat and we made a list of all the possible questions that we could think of. We spoke to a few previous registrars over the last 5 years and got their questions or what they thought had come up, even if it was just topics. And we just wrote down a giant spreadsheet of 100 questions and then planned it out and worked out that we could get through, 3-4 questions a night and worked out a way of meeting on Zoom. I was doing FRCS through the pandemic, so that actually worked quite well. Zoom was kind of new then, but actually I really do think it's a really good way just to maximise your learning. And we spent an hour in the evening a few times a week over those weeks and months before it and really rattled through loads of different things. And I found that really helpful. And then closer to the time, we basically each picked a list of our consultant colleagues who were most likely to give us an hour of their time, and each contacted them on behalf of the three of us and got a whole load of sessions in. So by the time we finished, I think we had about 20 hours with different consultants just doing an hour here with Mr. So-and-so who's really good at skull base, an hour here with Miss So-and-so who's a head and neck, and just picking their topics and asking them, look, could you do this bit? We haven't had any practice on this one yet, or we're really struggling with this one. And then in between those sessions, just going away and taking it in turns, going, look, we really didn't know the answer to whatever it was, paragangliomas. So, Rob, you take an hour, go and read about the management, read the guidelines, and can you just give us a 3-minute summary next time? So it was about being organised, and actually it really was about doing it in pairs. There's a lot of book learning, but hopefully by the time you've done the Part A exam, you've done that book learning. And so the B exam is all about just learning how to present that knowledge that you mostly have and identifying that for me, there were gaps actually that I didn't even know were gaps, but it was only when someone puts you on the spot that you don't have a succinct way of answering it. So yeah, it was really important to kind of speak it out loud.
Yeah, it sounds like collaboration, really important, divide and conquer the work, and short, sharp bursts of regular study and rope in as many consultants as possible. Brilliant.
That's right.
So for my last question, with your background as a musician, do you think that naturally led you towards otology?
Yeah, I think the two things for me was having been a classically trained musician, I really enjoyed that side of things. Although I would argue that probably everyone really enjoys music at times, don't they? It means so much to us all. But it certainly makes me think how devastating it would be to lose hearing. And certainly my role within the implant MDT in Brighton, I really enjoy when you can try and get people's sound back on. I think further to that as well, I'd had a mastoidectomy in childhood as well. And I do remember, some awful days at school, post-grommets, being sick on myself, was feeling sick and having pus pouring out of my ear when it was a wet discharging mastoid before it got fixed up. So I do, again, just really value a dry hearing ear and how much it is. And okay, the tinnitus is a bit annoying, but I really value what hearing I've got left.
I can imagine you having that personal experience and bringing that to be able to have that empathy for your patients is so important.
Yeah, I think it can be helpful from that side, and just little tips like I remember I had my head bandage on and I got it soaking wet early doors, and I tell you how itchy that is. So I make a real effort. For example, when we finished a mastoid and you've used a drill and it's irrigated and the hair's wet, just to take an Inco pad and dry it, just because a wet head bandage that's soggy that's on for 24 hours is a nightmare. So yeah, those little bits I think have been helpful. But there are also things that when you chat with patients, they'll feed back to you pretty quickly anyway. So as long as you chat to your patients post-op, they'll give you all of that insight as well.
That's very useful. I've never actually considered that. I'll think about that next time I'm wrapping a head.
Yeah.
So thanks for that. Let's move on to the clinical scenario. So our scenario for today, we have a 45-year-old woman who presented to the otology clinic with intermittent foul-smelling otorrhea and hearing loss in her left ear. And she has a known perforation for many years. There's no history of vertigo or facial weakness. So in this scenario, what would be your initial approach?
These presentations are really common in a general otology clinic, and I think for some people they're heart sink, but actually I actually quite like them. I think they can be quite interesting, and there's always something you can do, and the answer's never quite the same for each patient that comes in. Obviously, the first part of any exam answer is that I'm going to take a thorough history, examine the patient, and then tailor my investigations accordingly. But I think the three options that we've really got in terms of treatment for the above patient, conservative, medical management of a discharging ear, or surgical management, are quite different and need to be quite tailored depending on what you see. So definitely a thing I've started doing now when they come in is obviously I'm going to start with a thorough history. But as they're sitting down quite early on, I do get the otoscope out actually and take a look really early doors, because often that referral from the GP with a perforation turns out it's just a monomeric bit of tympanic membrane. Often there's a perforation is actually an attic perforation with a crust around it. And when you're dealing with a retraction, a cholesteatoma, or just a straightforward, inverted commas, safe past tensor perforation, the management and certainly the way you're kind of gearing that whole consultation is quite different. So I would advocate getting that just a glimpse early doors. Don't get me wrong, then it's important at a later date to sit down with a microscope and really examine carefully. But just so we kind of gear where we're going with our history, I've started to move into that quite early.
Mm-hmm. Yeah, that's interesting actually, because I've been caught out many a time where I've been referred with a query perforation and I've gone through the whole history and taken everything, and it's actually and explained the possible management scenarios, examine, and there's no perforations. That's actually a really good clinical tip. Okay, great. So we've outlined sort of initially what you want to do. Sort of from an exam perspective, what are the key buzzwords you want to be getting in to be achieving those high marks?
Yeah, absolutely. So certainly in terms of the full history that I'm going to be asking about, you want to know about the duration, frequency, and the nature of the discharge. What does it mean to them? What happens with them? Is this someone who's getting recurrent bouts of acute otitis media where it's painful and it perfs? So that by definition isn't chronic otitis media, it's just acute bouts. Or is this someone with a painless, continuous discharge that's been going on for a long time? So they're the chronic otitis medias. And does it dry up in between episodes? I always find quite important to know. If actually a single course of Cipro drops and keeping it dry in the shower and it's dry for the next year, then that kind of pushes us, away from wanting to rush into anything surgical. So I want to know about water precautions and what it's like for the patient. Yeah, okay, the past otological history is important. Ototoxic medication, family history, what their job is. Brighton, I swear every single person seems to be a music producer who's got an only hearing ear. But it's important to know that, really early doors, so that you know exactly what you're letting yourself in for.
Yeah.
And then there's often modifiable risk factors as well that you can elicit quite early on: smoking, a history of upper respiratory tract infections, allergies, sinus disease. So that's important. And then, of course, just knowing if they're a good surgical candidate in terms of their past medical history and drug history.
Mm-hmm.
In terms of the examination part, we've talked about getting an early otoscopy in, but once we're kind of talking to them, I get them lying down on the couch and examine them under the microscope. So do a bit of microtoscopy. If it's discharging, you can vacuum it away. You can assess the perforation size. You can see, is that perforation in the pars tensor or more worryingly in the attic. If there's a retraction, you can see if you can get that debris out, or if it's not self-cleaning. And I often take a swab as well, or get the nurses there just to pass me a swab early doors, right at the very first go, before we've given antibiotics or anything else.
Mm-hmm.
And
Okay.
all of my otology clinics come with audio. So again, audio on arrival, often before they've seen me in clinic, if possible. If not, rare that it happens, but then work through tuning forks for an ease and weathers test as well.
Mm-hmm. And do you ever conduct any free field hearing tests? Do you find value in that?
Yeah, I have to say, from an exam point of view, yeah, there was the Fs, wasn't there? That you're going to do your free field, your facial, and your forks testing. Although in reality, I don't think I've done a free field test since, I even talked about doing a free field test since qualifying, because I tend to rely on the audiogram so much. But I think that is lazy of me, and it's there. And certainly sometimes you have people with other things, non-organic type hearing loss, and you chatting to them at conversational tone. And you can do a kind of a mini free field and get a feel for where they are, and then their audio comes back vastly different. So in these situations, I'm just relying on what patients tell me, that they feel their hearing's often down. And it's kind of hallmark for chronic otitis media that they've got this painless discharge with typically reduced hearing. So we kind of expect it. Where the audio is really useful is in terms of counselling, in terms of hearing improvement or not. Some people actually have pretty good hearing thresholds overall, despite quite a large perf. And so then you can counsel them early doors that actually an operation is not going to change that, or not drastically going to change that. And conversely, the other way around, people with big air bone gaps, it really makes you want to take a really close look at what's going on inside that ear, examine the acicular chain if you can through the perforation or through the retraction, and try and kind of get your head around what's there. If the conductive hearing loss is more than 20, 30 decibels, it starts making you want to scratch your head about what else is going on underneath, and making sure you're talking about aciculoplasty as an add-on available for any surgery.
Yeah, okay. It's an interesting point, actually, going back a little bit about you saying with the non-organic hearing loss patients, how you can almost do a bit of a sly free field test, and then if that's grossly different to the PTA, then that's sort of ringing alarm bells, making you think of that. Great. Okay. So in terms of further investigations beyond audiometry, when would you be considering further imaging, etc.?
I don't routinely image when I'm looking at a pars tensor perforation that I'm considering for laryngoplasty. And I think that's probably in line with most people. But basically, I'm going to do a CT temporal bones, high resolution, at least 1 millimeter slices for anyone when I'm considering a cholesteatoma. And then there's a sort of a grey in between where there's a retraction pocket that extends out of view. So if, again, I'm questioning it, or they've got a long history of discharge or quite a drop in hearing, then I may get a CT scan again just to evaluate that. Sometimes in terms of alternative investigations, we've got angled endoscopes in clinic. So if there's a retraction pocket out of view, then I'll try and just get a quick look up at the edge of the pocket with those. And that can be quite useful. You get a picture and you can see whether it's progressing going forward. So I guess a CT scan for anyone who is suspicious of a cholesteatoma for.
Yeah, or you can't see the base of the retraction.
There is one other group as well, which is the DWI imaging. So again, somebody who's had previous surgery and got a cartilage graft over the drum, so you can't see what's going on. Then in those, I have quite a low threshold. We get people who have come in from a different hospital. They've had an operation in the past. They've got discharge. They've got progressive conductive loss. We don't really know what they've had done. And then that's the sort of time when, again, a DWI, non-EPI imaging MRI scan could be helpful, just in case there's a buried cholesteatoma behind previous surgery.
Yeah, fantastic. So moving on, with the clinical case in mind, how would you be structuring and considering your differential diagnosis?
So I'm going to admit early on for this one that I really struggled with the terminology used in chronic otitis media. I found it really difficult to get my head around. So in my mind, when I think about a discharging ear with chronic otitis media, painless discharge with conductive hearing loss, I'm thinking about someone with a perforation, someone with a retraction, or someone with a cholesteatoma. And yeah, okay, that perforation can be wet or dry, active at the moment, or discharging. But those are the kind of ones I'm thinking about. And if that perforation is up in the attic and is suspicious for cholesteatoma, then that's how I manage it initially. But those are kind of my three things. And the textbooks talk about a number of different terms, and so I'm going to just spell them out, just because it took me so long to get my head around the different ones. But essentially, the terms they use are mucosal chronic otitis media, which is the same as tubotympanic chronic otitis media, and that refers to a pars tensor perforation without worrying signs and without destruction of bones and scutum, etc. So a mucosal or a tubotympanic perforation can be active or wet, so terms dry or active or inactive. But I, in my head, just think of those as a kind of a pars tensor perforation. And then they have the other term, which was squamous chronic otitis media or attico-antral chronic otitis media. And again, it's referring to an attic or a superior part of the pars tensor perforation with destruction of bone and possibly cholesteatoma. And again, it can be active in a cholesteatoma or inactive in a retraction pocket, which then, just to make it more awkward, is sometimes referred to as an adhesive otitis. So there's lots and lots of terminology and lots of words that are used that are synonymous for each other. But I guess what it boils down to in my mind is perforations, retraction pockets, and cholesteatomas that can at any point be dry or wet.
Yeah, it's almost like these different sort of classification systems are either going with an anatomical theme, such as the tubotympanic or atticoantral, versus the almost physiological, is it active or inactive? And I think that's where it can get so confusing. So yeah, thank you for clarifying that, because I've actually really struggled with myself and tied myself in knots plenty of times before with that. Okay, great. So we've talked about active or inactive. We've talked about whether it's really a retraction pocket, a perforation, or a cholesteatoma. Other than assessing those three big things, is there anything else you want to be assessing in that examination or formulating a differential in your head?
Yeah. So once I've got them under the microscope and I'm taking a look, I'm going to get a swab early doors and make sure we've got that banked on the system before we start any antibiotics. And I always just want to start, if it's wet, by drying it up. So when there's a perforation there, it's getting some ciprofloxacin drops through and making sure that, even if that means seeing them back in the next clinic, just to make sure we've actually properly assessed what's going on underneath there. I think the other thing that's worth talking about at this point is granulation tissue and things. So sometimes you see those, and again, I have a very low threshold for just taking a sample of that and sending it off for histo if there is granulation tissue there. Just even for Brighton, we see one per year with a squamous cell carcinoma in the ear, and it's just enough just to kind of keep it on the back of your mind as well. Someone with chronic discharge and painless discharge, making sure you've ruled that out.
And other than neoplasia with granulation tissue, would you be considering any other differentials there?
I mean, I think the other ones for the exam point of view, so very rare, small print stuff, but TB, very occasionally we have systemic TB that can result from things. And thinking back with a case we had not that long ago, there were some risk factors in terms of exposure and immunocompromised, but actually their initial TB testing came back clear. But I guess the scenario in that case was someone with a CT scan that showed very widespread bony erosion that was just a bit weird. Lots of granulation tissue, no actual cholesteatoma ever seen. And so again, we got a sample of that quite early on, found tuberculous granuloma on histology way before the AFB came back on the MCNS. And then they went off and got their 9 months of rifampicin, isoniazid, and pyrazinamide and ethambutol, and did much better than that than they would have done with ear surgery. So I guess those kind of rare and wonderful type ones, similarly the kind of rheumatological type ones, every now and again creep up. In someone with chronic discharge and conductive hearing loss, so vagueness, I know it goes by a different name now, but occasionally you get those and occasional TBs. But really, the mainstay is going to be a perforation, less common than your retraction pockets and your cholesteatomas, and then your kind of weird and wonderful causes, rheumatological and atypical mycobacterial limits.
So I guess in a realistic clinical scenario, have perhaps TB and neoplastic differentials at the back of your mind. If you're not getting on top of the granulation, you've given multiple courses of steroids, you've cleaned, you've given the drops. I think, it's just worthwhile to have those in the back of your mind. Okay, so I'd be interested on your thoughts at this point, actually, on classification systems for middle ear disease. And if you find any of the classification systems, such as the SARDE or TOS system or the Wolstein classification system, of any use, or if you use any yourself.
Yeah. So I think, first of all, we've talked about the pathology itself, and we've talked about mucosal and tubotympanic, etc. So I think you need to know what those are, even though I do agree they're desperately complex terms. Then in terms of retraction pockets, so yes, for the exam, you absolutely need to know your SARDE and your TOS. I have to be completely honest with you. It's one of those things that, again, I learned because occasionally you read a letter and it's in there, but it's not something I ever use. And we've got endoscopes in clinic. When someone comes into clinic, if they've got a retraction, I'll put an endoscope in, I'll take a picture of it. That's then in their clinic letter, because everyone's on electronic notes. And then next time they come, I just look at what it's doing compared to the last time. And I know that, that's not magic and wonder. Loads and loads of units do exactly that. So I think with endoscopic images becoming widely available, they were quite broad terms, when you're thinking about a SARDE 1 to a SARDE 2, it's quite vague, it's quite nebulous. A picture's literally black and white.
Yeah.
And so that can be really helpful. So I don't use them very much in clinical practice, but you need to be aware of them just because of the exam, and B, the occasional time you get a referral in.
Yeah. Okay.
Wolstein, you mentioned, is interesting because it goes way back to the initial descriptions. The only thing is, for me, I don't think I ever use it, purely because just the terms, I think, are kind of moved on a little bit. So Wolstein 1, laryngoplasty, fine. 2 is where the malleus is eroded, but it's not something, to be honest, that you see very often at all. If the malleus is eroded, then usually everything else is eroded too, and that's pretty end stage. So it's not something that kind of crops up often. 3, porps. 4, torps. Okay, so I just use the term porp and torps, or describe the bit of the anatomy that's been eroded.
Yeah.
And then 5's become a fixed stapes foot plate. So that kind of verges into really otosclerosis for us now. So I guess in summary, Wolstein doesn't have a huge bearing on what we do, and I tend to just give an anatomical description of what I've done. I've repaired the pars tensor with tragal cartilage via a post-auricular approach, and long process of incus was eroded, so I've placed a porp brackets curse clip onto the stapes head. And that's very clear to everyone who's coming after, who has to pick up the pieces potentially, whatever it is, exactly what I did and why.
Yeah.
There was one final as well, which is Samia Atto. And actually, I do use that, but more in terms of collecting my own data. So I think most otologists now are understanding that you've got to keep an eye on all of your patients that you've operated on, your outcomes for your mastoidectomies, how many of them are getting recurrence, what their hearing outcomes have been. And it's actually been quite a useful exercise for me in terms of making sure that they're not lost to follow-up, because there's a few who kind of end up in other clinics, and actually I do want to see them back. But I think the second bit is in terms of being able to counsel going forward. So I can say to people, look, all your ossicles are gone. That means I'm going to need to place a torp. And however many over the last X many patients I've done, this has been the outcome. The data says it's 20% get a usable hearing ear with a torp. And at least you're sort of counselling patients on where you are in terms of your own results. And moreover than what the data says about torps, it's what you're getting with your results, much more useful than the data says this and the data says that. But if you know your own results, that's really useful. So Samia Atto has been really useful for that. And I put that on my own database, my own personal database, just so I have an idea of what I did and why. And I guess it's about communicating with each other, isn't it? So you've got the what's what and what you did. The problem with it is it's just so long and convoluted.
It is, isn't it?
That no one actually classifies like that. So perhaps a version 2 that's a bit easier to use might come out.
No, I think it's good in that it can give you very standardized way of collecting your own data for you to give your patients almost real-time data and complications and risks for their specific needs. I think, it can be useful in that situation.
Yeah.
So moving back to the clinical scenario, just to give you a little bit more information on the patient. So She gives a 2-year history of intermittent discharge from the left ear. She receives frequent courses of topical and oral antibiotics from her GP for this. She's otherwise fit and well. She's taking oral supplements only. She does smoke about 10 to 15 a day. Examining her, you can see some mucoid discharge in the canal. And after microsuctioning, you can see an attic retraction with some debris that you again microsuction to reveal a clean base of that retraction with a TOS score of 3. There's also a pars tensor retraction onto the head of the stapes, and there is appearances of erosion of the long process of incus. And anteriorly, there's a marginal perforation measuring about 3 millimeters in diameter. You get a CT of the temporal bones, and it reveals some sclerotic underpneumatized mastoid cells and confirms the LPI erosion. There's no evidence of superior semicircular canal dehiscence, tegments of fair height. You've got space anteriorly to the sigmoid sinus. There's no dehiscence of the tympanic jugular bulb, and the facial nerve is intact with no evidence of dehiscence. Audiology reveals a left moderate conductive hearing loss with a type B tympanogram and a large tympanic volume in keeping with a perforation. So let's go on to discuss how you would approach managing this patient given all the findings.
Yeah, I mean, as with all management options, you've got the conservative medical and surgical options. And so I'd run through all of those with her. I think in terms of when you're presenting that information to patients, you've got a little bit of a duty to make sure as well that you do make sure that you balance that with where we're going with this. And the bit that's a little bit concerning for me is that attic perforation, that there's debris that's accumulated there, multiple previous courses of antibiotics from a GP, both topical and oral, and it's still discharging. So whilst, okay, yeah, you could give some conservative management tips and stop smoking and take a swab and match the antibiotics topically to that, the reality is there's a good chance this is going one way, and at some point the surgical option is going to need to be discussed with her. In terms of the surgical options, you're going to want to know about the hearing status and the patient wishes about what they're looking for. Are they looking for a repair of hearing, or they really don't mind whatsoever? Rare, but I guess it's possible. And with that, you also need to know about where we are going forward for the retraction and what we're going to try and do with that. I think for me, I would kind of simple surgical options. Okay, there's some data on grommets and putting a grommet in for retractions and see if that prevents progression. I guess the difficulty with that in this situation is she's already lost hearing so far as an LPI erosion. So you're never going to be able to grow that LPI back. So even if you aerate things, you're still going to have that conductive loss.
Yeah.
So then at that point, you're talking about some sort of definitive surgical repair. Now, laryngoplasty is fine for the pars tensor perforation, but the attic part needs something doing. And at that time, you've got the opportunity as well to look at the ossicles and see if there's something to do there. So I think for me, with an attic retraction, trapped debris, an LPI erosion, and a pars tensor perforation, I'd be looking at maybe taking some cartilage, trying to raise up the drum and put some cartilage underneath to block off the attic, repair that retraction, and then do something like an ossiculoplasty as well with the cartilage on top, which whenever I place a port, I'll always place cartilage on top and use that same piece of cartilage while we're there to patch the perforation in the anterior part. There's loads of different ways you can do that, but for me, I find tragal cartilage works really nicely, and we'll keep the perichondrium on one side and then just the cartilage on the back side, take the perichondrium off the back, and I'll lift the whole drum up, lift the drum off the handle of the malleus, and then slide the cartilage over the top with the perichondrium supporting it, and then bring the drum back on top of that. And that would give a graft that would patch both the pars tensor perforation and part that would sit on top of an ossiculoplasty and fix in the attic at the same time, and then do the port while we're there as well. So that would be what I'd offer to her. But you could do other bits and see from there.
And when you're fashioning your cartilage, would you fashion a notch? How do you fit it around the malleus? Have you got any tips or tricks for that?
Yeah, it's definitely the first few I did didn't look as good as they should do, and it took quite a while to get there. At the moment, I'm taking a little sizer, so just cutting a piece of card or silicone from the table and making a template first, and then on that try and work out where the malleus notch will be.
Yeah.
And then I cut my tragal cartilage a bit bigger than you initially planned so that you've got excess perichondrium. I take the perichondrium annoyingly off the back wall, so that the anterior side of perichondrium seems to be a bit more robust than the posterior side, a bit in facing the ear canal. So I peel that side off, and then you've got a big piece of cartilage with perichondrium all around it, and take a round knife and flick off the edges of the cartilage, so you've got this overhang of perichondrium, and then put a little notch down the middle so it will slide over the top of malleus. And then when I lift the drum up, you slide it in. Hopefully, if you've cut your template correct, then it fits in really nicely. Although I have to admit, quite often I end up putting it in and then taking it back out to readjust the odd bit here and there, just so it fits in nicely. But I'm sure that's part of the learning curve that will come over the next 20 years.
They say that otology is more of an art than a science.
Yes, I'm sure it is, yeah.
So I guess bringing it back to a more exam focus, if you get a question like, when would you consider a tympanoplasty or a maryngoplasty? How do you define between those two?
Yeah, it's a really interesting question, isn't it? So for a pars tensor perforation, I would perform a maryngoplasty. That's on the assumption that the acicula chain's intact and they have a minimal conductive loss. And, you can argue either way, but the rationale in my mind is that a maryngoplasty is quicker, it reduces anaesthetic time, and you've got a problem that you can fix with a simple operation. So do the simplest thing that's going to get the result required. And I will still go to temporalis fascia. And I know that perhaps the more academic and clever thing to say is I'll always use cartilage, but I still do use temporalis fascia. It speeds up my workflow, it shortens general anaesthetic time, and it gets good results for me. In terms of approach, people describe using a fully endoscopic technique. I find that really challenging, but if they can do it, that's fantastic. Transcanal, endoral or post-auricular. So I end up with quite a low threshold to do a post-auricular incision. That's just what works for me, but you could argue any which way. I think it would be good for the exam point to think about how you would do this if you were given a maryngoplasty on your list tomorrow, how you would do it, just so you can just describe a technique that you would use. And I think FRCS level would expect you to be able to talk through the steps as you would want to do it. Not you can do, I would do, and just say how you would set it up.
That's good advice.
You mentioned about tympanoplasty. So again, that's when we're on to retractions and you're going to reinforce and examine the acicula chain on the assumption that there's something else going on there. And so we've talked about above a cartilage tympanoplasty with the presence of a PORP as well. In terms of outcomes, it's probably worth being aware of the differences between cartilage and using temporalis fascia. There's been a number of studies and then meta-analysis. So the initial ones with Matthew Young, for example, over in Cambridge, but later meta-analysis looking at the outcomes in terms of perforation rates and then also in audiological outcomes. So perforation rates, you put cartilage in, you probably get slightly better perforation closure rates, which I guess kind of makes sense because that cartilage doesn't disappear as quickly. In terms of audiological outcomes, actually, the bit that did surprise me a little bit with those is that audiologically, cartilage grafts do really well. You'd think, well, maybe they're not transmitting the sound quite right, but it doesn't seem that that's the case. Maybe they kind of resonate nicely on the eardrum. Maybe there's artifact in there about people who are, high-end otologists will do cartilage grafts, whereas maryngoplasty is kind of a more generalist skill. So I don't know what else is going on there, but certainly they don't seem to be audiological significant differences between cartilage and just straight temporalis fascia for maryngoplasty.
I always found that interesting. It's almost a bit counterintuitive, that. And what's your approach on thinning out the cartilage? Do you do it?
So I don't actually. I'd worked in a unit previously where they had a cartilage cutter and they used to thin things out. It did look really cool, but it did take quite a long time. So I have stopped doing that now, and I tend to just use the full thickness cartilage. And again, there's some systematic reviews that seem to show it doesn't worsen audiological outcomes. So I think that's probably my academic justification, but I think the practical justification is it's quite challenging to do. So I didn't, jump to it just because it's technically difficult to thin. And I've certainly messed up a few bits of cartilage when I was in training by trying to slice them down in the dicer and made a mess.
Coming to the end, what situations might you counsel patients against surgery?
There's definitely cases where I will manage a cholesteatoma and certainly a retraction pocket conservatively. sometimes you get people through who have minimal hearing loss, and younger patients as well who have minimal hearing loss. Actually, they use water precautions and it's dry. They've been sent in because they've got a perforation. So, GP seen perforation, referred for an opinion, great. But actually, when you speak to them, they're doing fine. And having 2 weeks off work from laryngoplasty, can't fly, they're doing fine. They don't swim, and they've got relatively good hearing as things are. They just will say to me, I'm not interested. So there are times, a number of different occasions across that spectrum of examples I've given, where, surgical options just might not be the best thing going. And it's certainly not reasonable to put things on hold and give some water precautions, dry the ear up once and see where you are in a year's time and decide to go from there.
And with those patients where you decide on conservative management, say, for example, a dry perforation, what is your follow-up plan with them? Do you discharge them from the outset, or I guess it can be variable to an extent?
Yeah. So again, thinking about all the complicated words we talked about for chronic otitis media, but perforations, retractions, and cholesteatomas. So in each of those, for a perforation that dried up with some topical antibiotics and the patient wasn't particularly bothered about having it fixed, I would probably place them on a PIFU pathway we do. So it means that they can come back for the same condition, not a different condition, the same condition again, by emailing the specific email at any point within 5 years. So that's probably what I do for them. I say, look, live your life, and if you change your mind next year, drop us an email and we'll see you again. For the retraction pocket, I'm going to want at least one follow-up to see what that retraction pocket's doing. And the duration of that depends, I guess, a little bit on the patient and the degree of the retraction and how worried I am. But I like to get a picture with the endoscope, and then a year later, another picture with the endoscope, and see that it's not progressed. And if it hasn't progressed, then we can be a bit more relaxed about things. But certainly, I'm going to want to follow up for that. I think for the cholesteatoma patients, we've all got patients who are those 90-odd-year-old patient, little Doris, who comes and she's got a cholesteatoma, but she's really not fit for a prolonged surgical procedure, and she's also agreed that she's not particularly keen on that. She comes in every 3 to 6 months. We microsuction out the cholesteatoma sac, clean it all out for her, and then she comes back 3 months, 6 months later for the same again. So the follow-up will be a bit variable, just depending on what of those three pathologies you're kind of dealing with.
Yeah, great. Thank you, Rob. I think that's a really detailed description of the various scenarios. So I think we're going to finish up there, really. Just to summarise what we've discussed, a clinical case of a lady with multiple pathologies of her tympanic membrane and middle ear. Things to consider are to, initially, you mentioned early on, actually examining the ear just with an otoscope, just to marry up what you're seeing with what they were referred is quite important. I think that was important to mention again. In terms of further investigations as well, considering when to request the MRI, DWI, non-EPI in patients who have previous surgery where, for example, there might be cartilage in the way of being able to fully assess the middle ear. We then moved on to discuss and hopefully clarify the different definitions of chronic otitis media being tubotympanic, atticoantral, active mucosal, or inactive, or vice versa with squamous. So thank you. That was really helpful, actually clarifying all of that. When looking at differentials, we talked about the importance of considering either the rarer diagnoses in failure of granulation to improve, such as tuberculosis or neoplasia, and getting a biopsy to help with that. We spent a good amount of time discussing your various approaches surgically for either laryngoplasty or tympanoplasty, and covered all of those approaches from permeatal, endoral, post-auricular, and when you might consider that, and types of graft material being either with fascia or with cartilage. And we discuss a little bit of the evidence basis and the fact that it's not very clear cut at the end of the day. So that concludes it. Have you got anything else to add, Rob, that you think might be useful or helpful for our listeners?
No, I think I could chat forever and ever about chronic otitis media, but I think we've covered the big ones, haven't we?
Yeah, brilliant. Well, thank you so much, Rob. I really appreciate it. It's been very interesting chatting to you today, and I've certainly picked up plenty of pearls for the exam as well.
Thanks, Anya. A real pleasure. Thank you. Thanks for having me on board.
One question for me, if that's all right, Rob.
Sure.
When we talk about performing a sacculoplasty at the same time as in doing an exploratory tympanoplasty and trying to assess the disease, do you have any school of thought about whether or not to do a staged procedure or to try and address this reconstruction at the time of your first operation?
Yeah, so with cholesteatoma specifically, right, that falls through to me depending on where I am in the operation about how likely I think I'm going to do a second look at a year and how likely I think I've got all the disease out. So sometimes you've got an attic cholesteatoma, you get in there, you manage to scoop it all out, and you're feeling pretty smug that everything is out. And then as part of doing that, okay, incus is missing and you need to sort your life out a little bit and repair the ossicles. But you feel comfortable that everything's done. At that point, I would typically go ahead and do an ossiculoplasty. If, on the other hand, I've got in there and it's been hard work and I've been fishing around in sinus tympani and you're scooping bits of cholesteatoma out from weird locations and you're using the endoscopes and you think you're done but you're not sure, those patients I'm likely to tee up for a second look at 1 year. And if that's the case where I think there's cholesteatoma, between the crura of the foot plate, rather than putting a PORP on at that situation or doing a TORP, then when I'm worried that there could be cholesteatoma hidden around despite my best efforts, those are the ones when I'll often delay that decision and see how we get on. Or sometimes just place a piece of cartilage onto the stapes head to give some sound transmission, knowing that then at the second look, if everything's clear, I'll have a bit of allocated time then to do a formal PORP or TORP, etc., as required.
Brilliant. Thank you so much. Thank you, Anya. Thank you, Rob. It's obviously been a pleasure to have you on the podcast. For our listeners,
Thanks, Josh.
thank you so much. And we're hopefully going to be producing more episodes soon, so please stay tuned, like and subscribe, and we will see you for the next episode. Thanks very much.
Thanks, Adam.
Thanks.